So, a warm good afternoon to one and all. And we are to start our instruction course on New Age Myopia Practice. Are you ready? So, why this IC? Because myopia is not just a refractive error anymore, it's an epidemic. And even CDC is thinking of considering it to be a disease soon. So, in that perspective, our IC is relevant. And we have eminent speakers lined up here. May I request Dr. Sumita to join me on the stage? And if Dr. Latika is there, please come up on stage too. So the first talk is going to be on myopia, not just a refractive error, but global pandemic by Dr. Ranjini Edge.
Good afternoon to everyone. So my talk is on myopia, which is not just a refractive error, but a global pandemic. So if we consider the global epidemiology of myopia, we all of us know that myopia is on the rise. And considering the logistics from 2000 to 2050, in 2000, almost 29.9% of the population is myopic. And by 2050, it will be almost half of the world population to be myopic. So why is it a pandemic? Because it has high prevalence now, early onset in childhood, and it is rapidly rising. And we all know it has so many lifelong complications. So when we look at the regional prevalence of myopia, mostly the Asian Pacific and the East Asian countries are largely affected, followed by slowly coming to the European population and North American population. So, and what is interesting to notice, in year 2000, this epidemic was amongst the younger age group, 10 to 39 years of age, which, if as per the logistics, will involve even the elderly age group by 2050. And of course, pediatric myopia is something which we should be worried about. It is on the rise, and 29.9% of the pediatric population will be myopic, and more than 5 billion will be by 2050. So what is progressive myopia? Myopia that worsens every year, and a progression of more than 0.75 diopter sphere per year is considered significant. So how do we assess what is the risk for myopia? So it can be done as risk of onset and risk of progression. So what are the risk factors for onset? Parental myopia, family history of myopia, both parents are myopic, ethnicity, East Asian population, limited outdoor time among children, excess of near work, and history of prematurity amongst the children. Also, low hyperopia in children is a risk. And what is the risk of progression? Younger age of onset, long study hours, competitive environment among children, earlier schooling, because parents are more worried about their schooling and their performance, so earlier schooling, reduced outdoor activity, and sustained near work, and closer working distance. Of course, poor lighting, using their tablets even for academic use on bedtime with all lights off in their tablets is a risk of progression. We all know the complications of high myopia. So apart from the aspect we consider, there is some economic aspect of myopia, which include economic burden, annual cost of myopia correction, and annual cost of higher myopes in the form of specialist care, which is really alarming. And also social impact of myopia. Visual impairment caused by myopia is a burden to the families as well, to the caregivers, to the communities they belong. And significant reduction in the activities in their day living, and visually intensive task which is required is affected. Of course, it affects their education, it affects their employment. Certain professions will require a very good vision, even with the glasses is affected, like in Army and Navy. Child development, because they are bullied, because they wear glasses, thick glasses, mental health, it all becomes affected. The children and their families as well. Also, it impairs the functional capacity, because if we consider older people, it may increase the risk of accidents like hip fractures and need for family support and nursing home. So all this is a very grave burden to our society. So how do we diagnose it? A good refraction, a good cycloplegic retinoscopy, axial length measurement, and a detailed anterior segment and fundus examination every 6 months. What are the strategies? Screening strategy. It starts at the school level. School screening is very essential, and early detection is the key, especially keys like training of our school teachers. So this is an American Academy of Pediatrics screen time guidelines, and as per this, less than 18 months, they should avoid any digital media or any video or any contact with the screen time. And from 1.5 to 2 years, very limited co-watching with the parents, high quality programs, and then it can be gradually increased to 1 hour per day for the elderly children. Along, of course, co-watching is advised. So digital eye strain is now a concern not even in adults, also in children. As per the two journals, one of the journals is from our own Dr. Nina, and it has shown that how digital devices in children is exacerbating the problem of digital eye strain, and it is affecting their overall development in the form of, development of squint, development of development of new squints, like in the form of acute esotropias. So we should encourage more outdoor time, more than 2 hours per day, UV light exposure, because it is supposed that it will stimulate the dopamine release, and it will prevent the axial length progression and myopia development. Also vitamin D from the sunlight, it will prevent the eye growth. And the pupil diameter being constricted, it will improve the retinal image quality and it will decrease the demand, accommodative demand. So this is just an overlayout of strategies for control of progressive myopia, which our speakers in the forthcoming session will be talking about. Future directions is, of course, the genetics, how it can affect our future generations, and AI is something which we have to be looking forward to. Thank you.
Thank you, Ranjini, for that overview of myopia slowly becoming a pandemic. We will take questions at the end. And now I invite Dr. Remya Edacheri to talk on From Atom to Lamp, what do we know about low-dose atropine in myopia?
Good afternoon. Thank you, Dr. Nina, for that opportunity. So I'll be talking on From Atom to Lamp, where do we stand? As we know, our patient care is always based on evidence-based medicine. Previously, we know the myopia had only glasses. Now we have a lot of interventions to prevent the progression, like outdoor activity to glasses to orthokeratology. So I will be talking mainly on myopia, atropine drops in the prevention of myopia progression. It's as you all know, atropine is obtained from Atropa belladonna, which is otherwise known as deadly nightshade. It is a non-selective muscarinic antagonist. It was first described by Wells in 19th century, and later on Bedsonian conducted a non-randomized trial on of atropine in myopia. So the mechanism of action is not actually understood, but it blocks the accommodation, but it is mainly the non-selective muscarinic antagonistic activity that is causing prevention of progression. So there are muscarinic receptors in the sclera that increases the scleral rigidity. It also affects the dopamine neurotransmitter release, which could also affect the growth of the eye. There are muscarinic receptor pathways in the choroid that is causing rapid and transial choroidal thickening. So antagonistic activity will be opposite to that. And sometimes what happens is when the systemic absorption happens, it suppresses the growth hormone from the pituitary gland, which could also affect the eye growth. So there are a few landmark studies. One is the atropine for treatment of myopia 1 study. This is a randomized control trial which is double blinded. You have the pie chart. That is the population is 400 children with 6 to 12 years in myopia less than -2 diopter and astigmatism less than 1.5. Here atropine 1% is put in one eye and the other eye is untreated, whereas the control includes placebo in one eye and other eye untreated. And they have looked for primary outcome as changes in spherical equivalent and axial length. And it was a 3-year study with 2 years of treatment and 1 washout period, 1 year of washout period. So according to this, you can see the uppermost part, the atropine treated eyes, the myopia was least progressed in that, around minus 0.25 diopter, whereas in the untreated eyes, it progressed to about minus 1.25 diopter. There was about 77% reduction in the progression with 1% atropine eye drops. So coming to axial length almost remained the same with atropine 1%, whereas all the untreated like placebo and other untreated eyes, it increased. So the conclusion of this study is that 1% atropine reduces the myopia progression. But we know that atropine has lots of side effects like loss of accommodation, blurring. So the child may have to use bifocal glasses for near vision and also tinted glasses for photophobia. So that's what ATOM-2 study is looking at. While we reduce the concentration of myopia, can we achieve the similar progression? So this is ATOM-2 studies, atropine for the treatment of myopia 2 study. This is also a randomized control trial, double-blinded, similar group of children. But here we should remember that atropine slightly lower percentage, 0.5, 0.1 and 0.01% in both the eyes. Previously it was only one eye. And placebo in the both eyes as a control. And similar outcome, and it was a 5-year study with 3 phases. The children were grouped into 3 subgroups in a 2:2:1 pattern. And comparing 1 and 2, it has a slightly higher, older children and larger myopia in the ATOM-2 study. The phase 1 was year 1 and 2, where it is treatment years. The phase 2 was a washout period, and phase 4 and 5, where the continuing progresses were restarted on treatment with 1 dosage. So what they found that atropine 0.01% has very little effect on pupil and accommodation, but the other 2 doses did cause pupillary dilatation and other problems. Now we compare the myopia progression. You can see the topmost one is the atropine 1% in the ATOM study, and lowermost is the placebo. So you can see the placebo, the maximum progression happened, and the atropine 1% is the least. But even the lower dosages had a similar effect with the atropine 1%, even though it is not as much as 1% atropine. And so lower dosages are almost as effective as 1% atropine, but in reducing myopia progression. And even if you compare the axial length, the same 1%, 0.05 and 1% almost had the similar, but in 0.01% there was increase in axial length. And you cannot compare it with an ATOM-1 study because ATOM-1 study used USG scan for axial length evaluation, whereas ATOM-2 study used IOL master. So you cannot just compare ATOM-1 and 2. So atropine 0.01% is the effective in reducing according to this study. So coming to the phase 2, where they have chopped atropine for, that is a washout period. But here you can see in the 3 groups, there was a rebound phenomenon, but it was least with 0.01%. It was sustained, very modulated in 0.01%. So even that has a less rebound effect. And coming to phase 3, where the continued progress are restarted on 0.01%, and they found out that even after restarting, it has stopped the myopia progression. So the final pearl is that you can advise for at least 2 years, decreases the myopia progression by 50%. Retreatment post-cessation is equally effective. So 0.01% is the most effective in myopia progression. And there is an ATOM-3 study not yet published. It is done in pre-myopes and low-dose myopes. And we know the problems with ATOM-2. There is no placebo in that group, and 0.01% atropine has not much effect on axial length. So we have to address these shortcomings. So that then comes the LAMP study, low concentration atropine for myopia progression study. So the research questions are, does LDA prevent the progression compared to a placebo? Is there a concentration dependent response effect? And what is the best concentration? So this goes through 4 phases. First year is the, here even lower dosages, 0.01, 0.025 and 0.05% concentrations are used. Year 2, the placebo group crosses over the group that shows maximum effect in the year 1. And year 3, there is a washout period except the crossover group. And year 4 and 5, extended treatment where the atropine is continued. So this is the population, and intervention and control I already told, and time period was about 5 years. So coming to the results, so you can see the lowermost one is the placebo, and the highermost one is the highest concentration. So the least progression happened in the 0.05%. And so also the axial length. So that takes us to the point that there is a concentration dependent effect on myopia control with low dose atropine. And 0.01% in this study, they doesn't seem to have any effect on axial length compared to a placebo. And so 0.05% atropine is the most effective in controlling myopia and axial length with minimal symptoms over 1 year. So concentration dependent effects in ATOM 2 study, it remained only in the first year. It did not hold for the second year. But here, both first year and second year, it held. So LAMP 1 and 2 shows that 0.01% is twice more effective than 0.01% over 2 years. And coming to phase 3, where there's compare the efficacy of continued and stopping the treatment, and also to evaluate over 3 years and investigate the rebound phenomenon. Rebound phenomenon, when you compare, there was rebound phenomenon in every case, and 0.05% atropine gives the best long-term myopia control with a minimal rebound. And phase 4, the long-term efficacy of low concentration atropine over 5 years, and also PRN treatment or retreatment using 0.05% is calculated. So here they found that the continued 0.05% atropine treatment demonstrated good efficacy of myopia control. So children should be considered retreatment if myopia progresses. So to conclude, atropine eye drops do reduce the progression of myopia. 0.01% is the most commonly available and commercially available atropine with the least side effects and lowest rebound effects. There is a concentration dependent response in reducing the myopia progression. We can start as early as 5 to 6 years of age. 0.05% is the most effective with similar side effects and can increase the dose in a non-responder. Thank you.
Thank you, Ramya. I know there are a lot of doubts in everybody's minds about when to start low-dose atropine, how to start, which dose to start with, when to taper. We'll take the questions in the end.
I would now like to invite Dr. Neena to talk about the next generation spectacle lenses for myopia control.
So thank you, Ksos, for this opportunity, and I warmly welcome all the co-instructors for this course. I'm going to talk about the next generation spectacle lenses for myopia control. So this is something new to us. We've been giving single vision glasses for myopia, and now we are told there are special myopia controlled glasses. What are these glasses? So one of them is the peripheral defocus spectacle lenses. Now, if you look at this first picture, that is that of an uncorrected myope. You can see that the light rays are focusing in the center, not in the center, in front of the retina. So what happens when you give a traditional single vision lens? The light rays get focused into the center of the retina, but look at the periphery. The periphery is getting focused behind the retina, creating a hyperopic defocus. Now, scientists, especially Earl Smith et al., have found out through investigations that this hyperopic defocus acts as a stimulus for the eyeball to further elongate, further increasing the myopia. So what do we do now? So they came up with a prototype of lens which creates a simultaneous clear vision in the center but produces a myopic defocus in the periphery, and they found that this was the best lens for myopia control. So based on that, the peripheral defocus spectacles have come into vogue, and this acts like a stop signal for the eyeball to further stop progression. So we have 3 prototypes in India: DIMS, or the defocus incorporated multiple segments, and you can see this is the Hoya MioSmart is a prototype. There is a central clear aperture surrounded by an array of multiple segments, each 1 millimeter in diameter and with a plus 3.5 diopters myopic defocus. So around 400 such segments are there surrounding the central clear zone, and this is in the middle periphery. So studies, especially this study which was done in Hong Kong Chinese children, found that it had 50% refractive and 60% axial length efficacy when they were worn, with an absolute effect of 0.44 diopter lower refraction and 0.34 mm less axial elongation. Now coming to the second prototype, which is a HALT, which is highly aspherical lensless target technology. Again, based on the principle of myopic defocus, you have a central clear zone for distant vision surrounded by 11 concentric rings of a constellation of 1021 highly aspherical lenslets. They are invisible, and each ring has lenslets of different power. There is a space in between each ring, and within the ring, the lenslets are contiguous. Again, the concept is to produce a volume of myopic defocus in the periphery. And this one-year myopia control study, again from Hong Kong, found that these lenses had a 70% refractive and 60% axial length control efficacy with an absolute effect of 0.4 by 54 diopters and a 0.23 mm less reduction of axial length in wearers in 1 year. The third prototype is the CARE, or the cylindrical annular refractive element. This currently marketed by Zeiss. You have two types, CARE and CARE-S. CARE has 7 mm central aperture. CARE-S has 9 mm central aperture. Again, the central clear zone is central has the power for distant correction, surrounded by cylindrical annular refractive elements, again producing myopic defocus in the periphery. And this 2-year prospective multi-center trial showed that this was definitely superior as compared to single vision lenses. Now we have another type of lens. This is not based on my peripheral defocus, but based on the principle that if you reduce the abnormal high retinal contrast signals, you can reduce myopia progression. So what they have done is they have incorporated multiple micro dots on the lens, thousands of micro dots on the lens, which slightly scatter light rays and produce mild reduction in the retinal contrast. And they found that reduction in retinal contrast acts as a stop signal for eyeball elongation and controls myopia. And this 4-year multi-center RCT also showed that this was effective as compared to single vision lenses. So there are so many lenses in the market. So I would like to share our experience with peripheral defocus glasses. So the study was done in our center in children with documented myopia progression, and we grouped into 2 categories, HALT wearers and CARE wearers. And what did we find? We found that the primary parameter we assessed was spherical equivalent increase and axial length elongation. And we had 34 patients, 68 eyes. The age, the sex, the axial length, mean spherical equivalent, all were comparable in the 2 groups. And we had more of rapid progressors in a study. That means they were progressing at a rate of 0.75 diopters jump every year in myopia. And this is the age distribution. We had more of children in 9 to 12 years age in our study. Coming to the results, if you look at the spherical equivalent progression at the end of 6 months, we found that 45.5% of the CARE wearers and 43.5% of the HALT wearers did not show any significant spherical equivalent progression. That means it was less than or equal to 0.125 diopters in 6 months. Whereas the axial elongation was less impressive. Only 31.8% of the CARE wearers and 39.1% of the HALT wearers did not show any axial length increase. However, at the end of 1 year, this was very significant. 93.8% of the HALT wearers and 75% of the CARE wearers did not show any significant increase in spherical equivalent progression. But however, the axial length control was less impressive. So we found that both HALT lenses and CARE lenses were best effective in moderate progressors, those who were progressing between 0.5 to 0.75 diopters per year. So what did we find? We found that HALT and CARE were comparable in their efficacy at the end of 6 months, but at 1 year, HALT had significantly better effect on reducing spherical equivalent progression and a slightly better effect on reducing axial elongation compared to CARE. Both the lenses, HALT and CARE, were most effective in moderate progressors, and both spectacles were tolerated well, no adverse effects. They were cosmetically acceptable and reasonably affordable, price range from 8,000 to 16,000 Indian rupees. So why is the study relevant? It's one of the first studies which compares HALT and CARE lenses in myopia control, and one of the first studies comparing HALT and CARE in South India. So when you looked at the other studies, I found only one published study from RP Center by Saxena et al., who found that they also had DIMS in their study, and they found that DIMS and HALT were slightly better than CARE at the end of 1 year in myopia control. Thus, to conclude, I'd like to say that these lenses are very much usable. They do work, and please do prescribe them if the parents are keen and affordable. And as they are non-invasive, they are easily accepted. And we found that at the end of a 1-year study in myopic children. Thank you very much. Kindly excuse me, I have to quickly go to the convention center for a short presentation. I will be back. Meanwhile, I call upon Dr. Sumita Muttu to give her presentation on myopia control contact lenses.
Thank you, Dr. Nina and Dr. Remya, for the kind invitation. It's a pleasure to be talking about myopia control contact lenses, because we've been working with these lenses for almost 4 to 5 years now. So I have no financial interest in these lenses. So I'll just begin with the typical case scenario that we commonly come across. First presentation was at 8 years. Current age is about 13.6 years. And you can see this is the kind of progression that the child had. We had introduced atropine quite early. But you see that despite atropine, there is a progression here. Okay, so it is in such case scenarios that we have to look for another treatment. So what do we do when a particular treatment fails? For example, the spectacle lenses or atropine, when it fails, that is when we consider the ortho-K lenses. So these are the typical risk factors that we look at whenever a child shows progression or whenever a child presents with myopia. First is the parental myopia, second is the outdoor time and the near activities. So this particular child had one parent with myopia, and outdoor time and near activities were all supporting faster progression. So we tried to reverse those. Despite that, the child showed progression. That is when we introduced the ortho-K lenses. And you can see over here that, So you can see over here, the circled area shows the control of the axial length. You can see that there is almost no progression in axial length. In the initial years when we were using the ortho-K lenses, we used to stop the ortho-K lens, give a washout period for about 2 to 3 weeks, reassess the refractive error to see if there is any progression. But I have learned in the recent times that you don't need to monitor the refractive error. You can just monitor the axial length, that is more than sufficient. So we do not give any washout period. We only record the axial length and perform dilated fundus evaluation on a routine basis and do over refraction on a routine basis to see if there is any progression. So I think Dr. Nina already spoke about how these lenses correct the peripheral hyperopic defocus. Ortho-K works also the same way that DIMS does. What it does is the contact lenses actually the contact lenses actually push the surface of the cornea, and then it thins out the central part of the cornea, the epithelium thins out, and in the periphery, the epithelium thickens. So this is how the ortho-K lenses work. So what are the indications for ortho-K? I think I've already discussed where there's a significant myopia progression. The first speaker already told us about what is significant myopia progression, anything more than 0.5 diopter. You can also consider it in children who are very, very active, for example, in sports, swimming, or they may be dancers. They do not want to wear spectacle lenses, and they do not want the hassle of wearing a contact lens and having some dust in the eye, etc. So again, in such children, it is an excellent option. What we have been doing is we have been considering these lenses in children who progress despite a myopia control strategy. For example, with atropine, they're progressing and they're progressing rapidly. Or with DIMS glasses or with Hall glasses if they're progressing, that's when we consider these ortho-K lenses. And also in certain children who are non-compliant, especially when it comes to atropine eye drops. So selection criteria for in our practice, it was at least the child has to be about 7 years. The youngest child that we have is about 8 years old, who's on ortho-K lenses. Again, the child has to be very compliant. The refractive error that it can correct is up to 10 diopter of sphere and up to 2 diopter of cylinder in case of normal ortho-K lenses, whereas the toric ortho-K lenses can correct up to 3.5 cylinders. Of course, there should be no surface pathology like dryness, allergic eye disease. There should be no ectasia or no thinning of the cornea or no suspicion of any corneal pathology. So this is the basic evaluation that we usually do. We do a manifest refraction, we do a cycloplegic refraction. We take a baseline topography, a pentacam. we look at the horizontal visible iris diameter. This is very important when you first choose which ortho-K lenses to put on trial. These other factors also play a role, for example, pupil diameter, lid position, etc. So how do we determine which lens to start with? See, usually these ortho-K lenses, they give a trial set. The trial set is given by the company and you train yourself, either a pediatric ophthalmologist or an optometrist does the ortho-K fitting. And for that, you need these following parameters. What is K code? It's the mean of the keratometry, the steep and the flat. The lens size is the overall diameter. This is about 93 to 97% of the horizontal visible iris diameter. This is simple. You can simply obtain this by calculating the wide to wide diameter on the pentacam. Then you also have the power code, which is the spherical error plus the astigmatism from the topography divided by 2. So this is how you calculate the lens size. By show of hands, may I know how many of you are already using ortho-K lenses? How many of you are interested in using ortho-K lenses? Okay, thank you. So, in which case I will talk about a few practical pearls and then we will not go too much into detail about the lens fitting because that won't be relevant when you're not already using. So, HVID can be measured, as I already told you, using the HVI ruler. I'll just show you the ruler later. So, this is the HVID ruler that we use to measure the size of the ortho-K lenses to be chosen. See, an ideal fit would be what you see centrally. That's called the bullseye pattern, where you see a flat cornea, no staining in the center, and then you see a periphery ring with staining, and then again a peripheral ring with no staining. This is called a bullseye pattern, and this is the ideal fit that you should be aiming for. So again, what we do is once you choose a particular lens based on these parameters, you put the lens on, you do fluorescein staining and look for the bullseye pattern. Okay, the patient has to put these lenses on and close the eyes for 1 hour. So remember that ortho-K lenses are night wear contact lenses that the patient has to wear and sleep with. The lid compresses on the contact lenses and then causes all of those changes, epithelial changes that I previously spoke about. Okay, and then after this 1 hour period, you repeat the pentacam to see how much flattening you have achieved. You also do a fluorescein staining to see how much flattening you have achieved and see if the fit is ideal or not. So an ideal fit would be this. Okay, you can see a good bullseye pattern, and this is how the pentacam would be when you repeat it after putting the ortho-K. So whenever there is an improper fit, you have to do some troubleshooting and see if there is a flat fit or a steep fit. So see, here you can see there is a flat fit. You can see there is too much staining, there is poor seal off, you can see there is stain even in the peripheral ring where there should not be any stain. And you see a smiley face topography like this. When there is a steep fit, this is what you see. I think we'll skip the fitting parameters and just go to our experience with ortho-K. We advise ortho-K for about 34 patients, out of which only about 28 patients cross the 1 year follow-up period. And therefore, we analyzed these patients and the mean follow-up was about 29 months. And what we saw was that in these patients, the axial length increased at a very minimum rate of 0.07 millimeter per year, which is of course statistically significant, but not clinically significant. And only 2 patients had contact lens related complications like punctate epithelial erosions and SPKs. So this is what we saw in 2 patients, and most other patients did not have any complications. There are various other multifocal contact lenses that are available which mimic the ortho-K lenses, but they are not as effective. I have personally used some soft contact lenses, but we found that this kind of axial length control and refractive error progression control we have not achieved with these kind of lenses. These are the other soft lenses which are available. So, so my message would be that ortho-K lenses is definitely a good option for treatment failure. It is preferable in certain demographics like sports people. Like we have a lot of patients who are active in sports like cricketers or footballers who are actually on ortho-K. And of course, it has a learning curve, but it is not very steep. Once you know your topography, ortho-K fitting is made very easy. And the chances of vision-threatening complications, remember, are far less. If you have fear of contact lenses in children, these vision-threatening complications are far less than the actual complications of high myopia. So definitely use this option, and these are easily treatable complications, so we need not worry at all. Okay, thank you for the opportunity. If there are any questions, we can take it up later.
Thank you, Dr. Sumita. That was a great talk. So I invite our next speaker, Dr. Latika Vasu Kamaladevi. Her topic is the future of myopia control, exciting new technologies on the cards. Over to you, ma'am.
Thank you. So at the onset, let me thank the scientific committee and Dr. Nina for this opportunity to speak on a very contemporary topic. So if I can see that the hall is full, and if all of you are very smug about being up to date about what is current, then this talk is about what is probably the future. So do we know? So your question, the first question may be, the present is enough for us. We live in the present. Do we really need to know all about the future too now? But actually, the future is here and it is knocking at your doors. So only the confident will be able to let the future in and, be in step with the future, because the future is colliding into the present. So what we say as futuristic is almost here. And your patient may be much more well informed, and it's up to you to be able to answer their questions. And most of our patients now come with futuristic questions rather than realistic questions. So understand, at least even if you don't practice, we should understand the multifaceted landscape of myopia control to adopt individualized and best practices for your patients. Now, the second question is, do we really need more, or all of this is just hype? Myopia is now a public health priority, and so there is a huge resource burden mismatch. And that is why this emerging tech is important, because it helps overcome resource limitations and it makes everything more accessible to the patient, and it helps in precision medicine, or the so-called targeted therapy, and self-paced interventions. And all of these which we discussed here probably addresses the compensation of myopia, but these mechanisms address the underlying causes of myopia. So that is why these things are so very important. And coming to an overview of these emerging technologies, we have digital health interventions, light therapy, we have AI-based interventions, gene-based interventions, and pharmacotherapy innovations. So for all this, we should understand that the basic mechanism is the signaling, visual elongation signaling occurring due to the peripheral hyperopic defocus, which was discussed probably in great detail, which trigger ocular growth. And there are many neuromodulators involved there, which finally leads to extracellular matrix remodeling and an excessive axial elongation leading to the progression of myopia. So digital health means it is a collage. It's an umbrella term that encompasses digital therapeutics, self-monitoring devices via technology. So what are these digital interventions? We have certain software interventions like apps and games that children can play. These are highly controversial because on the one side we are saying don't use the screen, and on the other side we are saying there are screen apps which you can actually use. And second is we have self-monitoring devices and apps which aid in continuous remote monitoring. So these two things are digital health interventions. This is a device for that. AR technology means, see, there is something called wearable devices which can be worn, and they simulate outdoor environments and vision tasks, and reduce the eye strain, ensure improved posture, and they again, we can incorporate this peripheral defocus into those devices also. So all these devices are such examples, and I will just be focusing on one such. That is the NED, or the AR smart glass. This is worn just 2 centimeters in front of the eye. The basic thing is the image is projected right into the retina by this glass itself. So the eye does not need to do anything. The eye is in passive mode. So When such glasses are equipped with a light transmissible part and an opaque part, then they become an AR computer, and they can be, actually connected to your smartphone also. And what this does is this light transmissible part is equipped with convex lenses. That peripheral defocus thing can be combined with this also. So this is where it is going. So these many advantages they are saying for these NAD glasses. There is no glare, there is no need to turn on lights because you are using sunlights, no reading glass, etc., etc., etc. But the thing is that the FDA is not yet cleared this. That means there are regulatory problems with this glass. So these are some other devices. The first one is a Kubota glass. It's a wearable device designed to control myopia control. It projects defocused images to the peripheral retina. Again, peripheral defocus. Now, there are some vision training exercise glasses available. And the second one, this one is a clue clip device. It's a wearable that can detect light intensity exposure levels, and it can modify unhealthy work patterns. So digital health has, much patient satisfaction and engagement, and it is tailored to individual patient needs. But there are challenges like high cost, lack of robust clinical evidence, etc. Now we come to the next section of genetics. This addresses the root of the problem. So these are the key genes. The ones that I have highlighted are some of the key genes. And gene therapy, that is virus-mediated gene delivery, etc., are being explored to correct genetic mutations, reversing myopia progression. Whole gene replacement is also on the queue. These are all, research and experimental right now. But this is not like that. It is light and environment-based therapies. Outdoor exposure is probably the most affordable form of light therapy. It works by triggering retinal dopamine release and reducing accommodative strain. At least 2 hours per day is the recommendation. And there are many challenges in its implementation, including UV exposure risks. Architectural interventions means modulate classroom lighting itself to meet these luminance requirements. Now, apart from this, there are certain emerging light therapies like using red light and even violet light. So these are the specifics of these light therapies, which I will not go into. But I'll only say that RLRL is leading this game now. And long-term safety data is again limited for that, even for RLRL. And there is a rebound effect also. After stopping therapy, there is supposed to be a rebound effect also. These are concerns regarding RLRL. Whereas violet light therapy, the evidence is very limited. It's RLRL that is being explored. So the challenges are, again, this is FDA unapproved, cost factors are there, accessibility factors are there, long-term safety factors, and we don't know the optimal dosing protocols as such. Now coming to the AI in myopia. AI apps rely on big data. It can be machine learning, deep learning, etc. And in children, it is used for mass myopia screening and predicting progression, and also for ortho-K results and to evaluate, how to fit it correctly, etc. In adults, it is for predicting myopia-related complications and surgical outcomes. AI again has the promise and the peril. The promise is that it is enhancing diagnostic precision, reducing strains on resources, and huge economic advantages. The peril is about the data quality and regulatory issues. So again, the last one is pharmacotherapy. It acts on this neuromodulator pathway. And these are all the target molecules of pharmacotherapy. The current status is that human trials are there only for atropine, pyranzipine, and methylxanthine. Only these, of which atropine is, of course, the most consistently used now. And pyranzipine is still to, have acceptance. And in clinical trials, these are the molecules being tried, that is ketorolac, riboflavin, brimonidine, etc. But it's largely experimental, and no pharmaceutical agent has been actually approved by US FDA right now. So in short, challenges of emerging technology are cost, availability, accessibility, regulatory approval, and robust scientific evidence. Combination therapy may be the way to go. And the most common combination advised is pharmacological and optical. That means, for example, ortho and atropine. We have also others coming up, other combination therapies. So in summary, emerging interventions show promising results, but there is no single solution for all patients. Individualized and combination therapies offer the best chance, and the challenges are adherence, access, long-term data, and population-wide implementation. Future success will depend on early intervention and public health engagement. Thank you all for your kind attention.
Thank you, ma'am. So, Dr. Neena, ma'am, she will be doing her next talk on real-world scenario of progressive myopia, case-based discussion.
So I want this to be an interactive session. So I have put across some cases which have come to my OPD, and I would like to have the opinion of the expert panel and even the audience. So this is a 15-year-old girl with uneven birth history using glasses from 5 years of age. She was on regular follow-up till COVID. Then she was lost for follow-up. Then a year back she came back, and then she came up with she came after COVID with progressive myopia. No family history of myopia. So this is her, current glasses. With current glasses, she's reading 612 N6, mild myopia with astigmatism predominating. But her current cyclorefraction had shown there was a jump of 0.75 diopters in the right eye and 0.75 diopters in the left eye. So axial length was also recorded. What will you do for this patient? Now parents are concerned. She said she had changed her glasses about 6 months back, and now there is a big jump. What will you do? She's 15 years old. So what would you do, Dr. Sumita, in this scenario?
The age is the factor that you need to consider. Parental myopia. So I think no parents with myopia. And she's a 15-year-old, means she's crossed the peak years of progression. And though the recent change is of concern, what we see in our scenario is these 8th, 9th and 10th board people typically show a progression during that time. Yeah. So though literature says that the peak years of progression are until 13, 14, in my experience, what we have found, I'm sure you've also found that we still continue to see progression until about 17 or even 18 years in some children. So we cannot take this lightly. So definitely I would start at least a low dose atropine in such a child. Also give the option of spectacle lenses, myopia control spectacle lenses. So depending on the affordability, either of them to be started.
So that's exactly what we did. We started her on low dose 0.01 atropine at bedtime. And we advised 6 monthly follow-up. So at the end of 6 months, she was stable on low dose atropine. Axial length was evaluated, and she was advised 6 monthly follow-up again. At the end of 1 year, she was stable on low-dose atropine. So these are the pointers which she already mentioned. So we can maintain her on low-dose atropine as she's nearing adulthood, and she may stabilize spontaneously. Coming to the second case, that of an 11-year-old female child, again, little higher myopia, again, no family history. But there was a jump of about 0.5 sphere in the right eye and 0.25 sphere in the left eye with some changes in the cylinder. So they said they had changed the glasses 6 months back, and they were concerned about frequent glass change. What do we do now? Again, here we started low-dose atropine, and single vision glasses were given. At the end of 6 months, again there was a jump. The myopia was progressive. This time there was a significant increase in spherical equivalent and axial length was noted. So there was a rapid progression. So what would you do in this case, Ramya or Dr. Sumita?
Either we can increase the dosage to twice the atropine daily, or better here if there is an axial length change, so better to put on 0.05% atropine or start on a progressive glasses.
Yeah. So, so these are the pointers here. So initially mild progression, but there was a rapid progression. But remember, she's not having family history of myopia, but this is a younger child in growing phase. So these are the options we could give. We could make the low dose atropine twice daily, or we could switch over to 0.05, a higher concentration, or we could directly give peripheral defocus glasses. So they opted for twice daily atropine, and that's what we did. And what did happen? After 6 months, she was stable. So she was advised to continue the low dose atropine twice daily. But at the end of 1 year, yeah, again the refraction was stable. So an axial length, there was a minimal change, but since refraction was stable, we maintained her on single vision glasses with twice daily atropine. Coming to the third case, a 12-year-old boy, normal developmental milestones, but mother is a myope. So current PG showed a jump of about 1.25 diopters in myopia and 1.5 diopters in the left eye. So very rapid progression in the 6 months. So axial length was recorded, and this child gave a history of having used low-dose atropine earlier, but had discontinued it because of non-compliance. So parents were concerned about the rapid progression. What do we do now? Dr. Sumita, would you like to answer?
The age again, Dr. Nina?
Age was he's about
12 years.
12 years, yeah.
Okay. So a 12-year-old boy showing significant progression. Again, there was some progression in the cylinders also noted. Just make sure there is no history of eye rubbing, rule out any corneal ectasia because we're seeing a quick progression. That is one thing. And considering this parental history of myopia and he's just 12 years, he is going to show significant progression. So at this scenario, I would like to discuss about compliance with atropine with the parents. If they think the child is not going to be compliant or they have a very busy schedule where they cannot ensure compliance, then the best thing to be to go forward with would be defocus glasses or ortho-K lenses is something that I would definitely like to counsel the parents about.
Yeah, so that's exactly what we did. And the parents didn't want atropine because child was not compliant. So we opted for peripheral defocus glasses, that is HALT or CARE was explained, and they chose HALT Essilor Stellus lens. And what we found after child is on regular follow-up, at the end of 22 months, child is stable on HALT lenses. So he's advised to continue the same. So these were the pointers she has already explained. Now, this is an 8-year-old boy using glasses from 4 years of age. Both parents are myopic here. And you can see 8-year-old boy with significantly high myopia already, minus 6.5 diopters with a minus 1.5 diopter cylinder, and significantly increased axial length also. Parents are concerned about further progression of myopia. They said they changed glasses 6 months back, but again a jump. What do we do now? So, what do we do now? So this is a very significant myopia. And so we started the child on low-dose atropine 0.01 with single vision glasses. After 1 year, again, big jump, 0.5 increase was noted. So what do we do now? We made the low-dose atropine twice daily. Now, again, jump after 1 year. It has increased by again 0.5. Despite being on twice daily, what do we do now? So, Dr. Latika, would you like to put in some points? What could we do now? Already atropine has been made twice daily. Remember, at this time, we didn't have 0.05 atropine at that time. We only had 0.01. So that's why we made it twice daily.
Yeah. So I was thinking about 0.05% atropine actually as the next step, but probably a combination therapy using multiple modalities may be the way to go.
Yeah. So this is, if you don't, since we didn't have 0.05, we went ahead with gave the option of special glasses, myopia defocus glasses with atropine. And that's what we did. The glasses were changed to Stellest and low-dose atropine was continued. But again, at the end of 1 year, there was increase in axial length and spherical equivalent. What next? Now we have tried everything in our armamentarium. Only one thing is left, about which Dr. Sumita discussed, orthokeratology contact lenses. We gave the option to the parents, but they didn't want to use contact lenses because of problems with hygiene and health, and we decided to continue the same. But this is one place where you can definitely recommend orthokeratology contact lenses. Thank you very much. I hope you got some take-home pointers. And I thank all the co-instructors and the audience.
I would request Dr. Nina ma'am to please hand over a memento to Dr. Sumita.